Okay, we are live. And good day, everyone. I am Dr. Sasinder. I welcome you all to the Indo-Argentinian shoulder and elbow meet today. We have a large membership of opinion leaders from Argentina, Colombia, UK, and from India. I hope you enjoy the program today and have a lot to learn from today. So let me share my screen and introduce all the speakers and the panelists for today. So Dr. Daniel Moyer. Dr. Daniel Moyer is orthopedic surgeon and shoulder specialist from Hospital Británico de Buenos Aires, Argentina. He is also former president of Argentinian Shoulder and Elbow Society and Latin American Shoulder and Elbow Society and International Shoulder and Elbow Congress of 2019. He is also a member of the International Board of Shoulder and Elbow Surgery, former president of the International Society for Medical Shockwave Treatment, and current president of IBIRO Latin American Shockwave Society. Welcome, Dr. Daniel Moya. Thank you for accepting to organize this program for us and also contributing your knowledge. We have Dr. Juan Carlos Gonzalez, chairman of Department of Orthopedics, Fundación Santa Fe de Bogotá, professor, School of Medicine, Universidad de los Andes, Bogotá, Colombia. I'm sorry if my pronunciation is wrong. Thank you very much, Dr. Juan Carlos, for accepting to share your knowledge with us. Then we have Dr. Juan Pablo Simone, shoulder and elbow surgeon from Hospital Alemán, Buenos Aires, Argentina. He is president of the Argentine Shoulder and Elbow Association. He is also co-director of Orthofleximal. I'm totally in love with Orthofleximal. I mean, the way the videos are put up is very good. I guess we are going to see part of the videos in his presentation. He's also coordinator of advanced course in shoulder and elbow surgery at Universidad Católica Argentina. He's reviewer of Journal of Shoulder and Elbow Surgery, and is also Mayo Elbow Course surgical instructor. It's wonderful to have you, sir. We also have Dr. Diego Jose Gomez, shoulder and elbow specialist from Hospital Británico de Buenos Aires, Argentina. Welcome, Dr. Diego. On our panelist is Mr. Radhakant Pandey. Dr. Radhakant Pandey is consultant orthopedic surgeon from NHS Leicester, UK. He's shoulder and elbow surgeon and also has interest in foot and ankle sports surgery. We also have Dr. V Pandey, Associate Professor, Sports Injury and Arthroscopy Division, KMC Manipal Hospital, India. He's Secretary of Shoulder and Elbow Society, India. He has done a shoulder and elbow fellowship in Netherlands and Italy and has a lot of research interest in rotator cuff, shoulder instability, PRP, and stem cells. He has a lot of book chapters and more than 55 publications in his record. And hosting the program along with me is Dr. Srinivas Kambambati. He is arthroscopy and arthroplasty surgeon from Sri Datri Center, Vijayawada, India. He is also associate editor, Indian Journal of Orthopedics, Journal of Clinical Orthopedics and Traumatology, and Journal of Arthroscopic Surgery and Sports Medicine. And myself, Dr. Sasinder, and shoulder and elbow surgeon, knee surgeon from Apollo Hospital, Muscat. So, it's not possible to introduce all our faculty today properly. Their CVs run for pages together, so I will stop short with this, and I kindly transfer the program to Dr. Daniel Moya.
Thank you very much. Namaste to all. It's a pleasure to be in touch with you, even by this platform. I want to give you the greetings on behalf of the members of the Argentinian Shoulder and Elbow Society. And being the old of all of us, I have the chance to tell you what I have seen in the last 40 years related to the treatment of rotator cuff tears, because there have been many changes and many things going on. I can tell you that I have seen many diagnosis error being made. And this is an important point, especially for young people, because when we begin, we have the enthusiasm for surgery, and sometimes this will lead us to mistakes. Look at this. This was a woman that with this MRI was operated and underwent arthroscopical decompression by her surgeon, and she did not get well. 2 years later, he went back to her surgeon, and having this MRI, his surgeon told her, "You need now an open surgery, so let's wait." And this woman was a very good patient. She waited for 2 years more, and I received her 4 years later after the arthroscopic surgery. And in fact, what she had was a tuberculous osteoarthritis. So sometimes things can look like one pathology, but in fact are something completely different. This was a 55 years old patient with shoulder pain for 1 year. When I received him, he had gone through 2 arthroscopic subacromial decompressions, but he continued with severe pain and with a situation that we must have be like a red flag for us, because the pattern of pain was not the usual for a subacromial impingement or a tendinopathy of the rotator cuff. And in fact, what he had was a lung cancer metastasis that was located in the subacromial space. You can see it here. Very strange case. But these cases are common. I could show you many cases that I have collected during the last 30 years, let's say. This is another case to finish speaking about diagnosis, a 67 years old patient with shoulder pain for 1 year. He came with this MRI saying, "I have a rotator cuff partial tear. I have visited 3 surgeons. 2 told me that I should go through an arthroscopic surgery, and 1 told me that I am a candidate for an open procedure. What should I do, open or arthroscopic?" But I did not look only at the rotator cuff. I watched the humeral head. There was a strange image there, and this is a problem. These patients many times have only an MRI, or even worse, now we are getting fan of the ultrasound performed by the orthopedic surgeon at the office of the orthopedic surgeon. But many times there are things going on in the humeral head. And I asked this patient an X-ray, I asked a scintigraphy, and in fact, this patient had a prostate cancer metastasis, and he was going to be operated of a partial rotator cuff tear. So in these cases, if conservative treatment would have done in a very good way, could have had some options, some possibilities to calm down the pain, but especially to give us the chance to examine the patient a second or a third time and realize that something different was going on. It is a bad idea to go directly to surgery in these cases. Another thing that I have seen is that conservative treatment many times have been underestimated and wasted. Unfortunately, I trained with Dr. Rockwood, and I know the importance of the conservative treatment. So there are many things published that shows this. For instance, these were 104 patients that were operated because of a subacromial impingement. And as you can see here, 50% of them were direct to surgery and did not receive any kind of previous exercise program. Again, it is important in those patients in which it's possible to obtain a good result with conservative treatment to perform the conservative treatment, and the surgeon must be involved in this treatment and must know about this treatment. A third thing that I have seen is that there is a great variability in therapeutic decision making amongst different surgeons. And this is already published in this paper. There were more than 300 surgeons responding, and it was shown that there was a significant variability in decision making and a lack of clinical concordance. Also, in this paper, they analyzed the indications for repair of the rotator cuff, and most of the studies did not describe the reason for the surgical indication. So there is a problem for us that I know there are so many variables about the lesion, about the patient, that it is difficult to have a uniform decision-making prognosis. But there are also geographic variations. And you can see here, even in the same country, in Mississippi, they operate 9 patients every 100,000 population. In Michigan, 27, and Idaho, 65. Why? Well, there are many reasons for this. And sometimes the reasons are related to the different codes, administrative reasons that are applied to pay the surgeries. So the surgical rates have many conditionants that they are not always, and many biases that they are not always discussed as they should, because this is part of the problem. I have also seen the peak and decline of acromioplasty. In the 90s, I'm sure Dr. Juan Carlos Gonzalez as well, we have performed many acromioplasties, but as you can see here, from 1996 to 2006, there was an important rise of acromioplasties. But as you can see in this other paper, after 2006, there is a decline of the number of procedures, especially after Dr. Madsen's paper. And I'm sure that Juan Carlos, who know very well Dr. Madsen, will have something to say about this. I have also seen many advances and contradictions in surgical techniques. And the first surgery in which I participate was a surgery done by my father 40 years ago. I was a medical student, and he performed the McLaughlin technique, and he proceeded with an osteotomy of the lateral acromion. We repaired, it was an acute rotator cuff tear. It was a sailor. And after that, we put the patient in this kind of plaster for 6 weeks. After that, that lateral acromiectomy that we perform in the last 40 years, I have seen that after that near imposed the anterior-inferior acromioplasty. But then Rockwood said, no, it is better to do it in 2 steps. Then we have the arthroscopic acromioplasty, and then they told us, you shouldn't do acromioplasty. What about and now we are going to the lateral acromioplasty again. So it is interesting how things have come and go. Again, with the acromioclavicular, with the acromiocoracoid ligament, we used to resect it. Then they said, do not resect the coracoacromial ligament. The repair was at the beginning transosseous. Then it was better to use anchors, titanium anchors, then resorbable anchors. Then we went to PIC anchors. We discussed single row, double row, suture bridge, arthroscopic transosseous repair. So we went back to the transosseous system after going through many different techniques. Rockwood used to advise the use of debridement, When the repair was not possible, then they told us that latissimo dorsi transfer is the best way. Now we are talking about, lower trapezius transfer. We have balloon spacer, superior capsular reconstruction, reverse arthroplasty. So you can see in 40 years how many options, and some of them are opposite options. What is going to be the future? What the future is going to bring us? We don't know. I have seen in these 40 years the same person saying, I have never seen a rotator cuff that I cannot repair, and several years later saying we should perform the superior capsular reconstruction. So it was not that like what he said in the beginning. So it is difficult to uh, find something clear or uniform, seeing the things from a point of view of 40 years. If you compare McLaughlin procedure 1944 and Burkhardt procedure 2003, besides the approach, there are not big difference in the repair. And many years went from one procedure to the second one, but there are not big differences. Uh, Even more, we keep on discussing which are the advantages of the arthroscopy. We know that there are many advantages, but clinically, if we consider the follow-up, this paper was published by George Atwell last year, 2019. He did not find big differences on function, pain, and range of motion comparing open to arthroscopic repair. In fact, I think that we have tried to conceal with surgical gestures our inability to provide a biological solution. Because here, the protagonist is the tendon, is not the repair. And unfortunately for us, orthopedic surgeons, we have made the technical procedure the star of this movie. And speaking about movies, sometimes I feel that we were doing this. I don't know if you all remember this movie. That was a very fun movie about a guy that you can see him in the middle that was dead, and his friends were taking him on holidays everywhere, but he was already dead. And sometimes we did the same with the rotator cuff. The tendon was dead, and we were playing to how to repair that, but we were repairing a dead tissue. I think that there are some concepts that were misunderstood. One thing is reparability, another thing is biological responsiveness, and another is functional ability. Reparability was related to the amount of retraction and the humeral acromion distance. But you can see patients like this one with a big retraction, you can see here, and with a very short acromio-humeral distance, and it was possible to put back the rotator cuff in its point, in the place it should be. The same patient, another case, the X-ray shows a good acromio-humeral distance, but you can see here that the MRI shows something completely different. So it is sometimes difficult to find a reliable prognostic factor. I think that the point is also the biological responsiveness. If I can repair a tendon, but the tendon cannot respond and not heal, it will be not necessary to repair it. And there are not many classifications evaluating the quality, the biological quality of the tendon. This is a nice one by Riley, and he says that in grade 4, when we have severe degeneration, the tendon will never heal. So to make things even more complicated, there is not a correlation between the type or the size of the injury, of the tear, and the characteristics of the tissue. So we cannot extrapolate what we see on the MRI to the biological responsiveness. Finally, we should talk about the functional ability, and we consider the atrophy of the muscle belly and the infiltration, the fat infiltration described by Goutalier. But there are some papers that have studied the amount of fat in the muscle belly, and they do not correlate with we see on the MRIs. I have also seen the development of diagnostic methods that allow us to understand much better the problem we face, and those are good news. Now we have options that for sure will be developed in the future that will give us not only information about the size of the tear, but also the quality of the tendon. And that is going to be very important for us for decision making. I have also seen the advent of new reconstructive techniques when the calf cannot be repaired, and you know all of them, and I think that are very interesting, but we must consider that they are not always necessary. And this paper by Alexander Lederman, is very interesting, that there is no evidence to show that latissimo dorsi transfer in type E choline rotator cuff tears is better than a partial repair. So sometimes it's not necessary to put the patients through a very complicated and big surgery, and especially unpredictable result when we have perhaps to begin to the chance to perform a surgery that is not so complicated. This patient was a 70 years old woman that was referred to me with a pseudoparalytic arm and indication of reverse arthroplasty, but was just a matter of calming her pain, putting down her pain, and rehab program at home, and she completely recovered the movement with no pain. So again, there is always time to go to surgery when it is not an acute tear. I have also seen the advent of regenerative techniques, and we all know about that. They are in the market and they are growing every day. There were serious studies about this, like this one by Rodeo, but there are also many things going on. And for instance, the Dr. Bill Malone from the JSES warned that the clinical data is limited, and many treatments are still unproven. This is a patient, 71 years old patient, a doctor that has some very mild pain when playing tennis, and he received the advice of having a PRP shot on his shoulder, and just with one, he got septic osteoarthritis, and now he cannot move his arm. So we must be very serious, because it's very easy to make the decision when it is not our own shoulder. I have also seen many techniques imposed by commercial pressures in these 40 years, especially in the last 15 years. And as Juan Carlos Gonzalez says, rotator cuff repair is one of the best examples of planned obsolescence. And we should be very careful about that. I have also, to finish, seen many colleagues who, beyond any commercial interest, have sought the truth and the best way to treat their patients. And I want to give a tribute to Dr. Rockwood, that I know very well, and the colleagues that are sharing with us this session today. Thank you very much.
Thank you very much, Dr. Moya. That was a very, very interesting session. It is very much important to know what we should not miss and what we should not do before we know what we want to do. Or we can't miss the old sayings that the basic investigations have to proceed. We can't miss an imaging with an X-ray before we go ahead with an MRI scan, and we have to make sure we don't miss very important red flag signs with respect to infection or so on. So thank you very much. That was a very, very interesting program.
Thank you.
I kindly request Dr. Juan Carlos Gonzalez to talk about the indications for rotator cuff tears repair. Over to Dr. Juan Gonzalez. Sorry, Dr. Juan, sorry, you were muted. Now you're unmuted. Now you can go ahead. I'm sorry, I'm doing it for you.
Can you see my slides here?
Yeah, we can see your slide and we can hear you.
Okay, thank you very much. Thank you for the invitation, Dr. Sasinder. Thank you to your colleagues. I'm very honored to be here. Very happy to be with my friends from Argentina. Daniel and me, we think very alike, as you will see in my talk. We were lucky enough to be with Dr. Rockwood many years ago. I am old also, but I have more hair, so I look younger than Daniel, but we are almost the same age. So Dr. Rockwood had a great influence in us, and you will see that in this talk. Probably the easy way to do this talk would be to say, just operate in everybody. If you have a rotator cuff tear, go on, operate it. Why not? And unfortunately, many people think like that. I will try to talk different about that. The Fundación Santa Fe de Bogotá is there. You are welcome anytime in Bogotá. I will put forward in this talk the recommendations that I think that are perfect to operate. Acute ruptures, no doubt about that. Persistence or recurrence of symptoms, and increase in tear size. It's easy to talk about these indications because I would say everybody agrees with this. Talking about acute ruptures, there are a few papers about this. This is from England, from the United Kingdom. Dr. Pandey surely knows this. They have a social security system, and some patients cannot be operated acutely. And when you compare those who are operated acutely and those who are not, you can see the difference. We have known this for years, but this has been demonstrated in the literature. Talking about persistence of symptoms, you don't have to think that symptoms of rotator cuff are small. Sometimes they are really intense, and many times they contribute to problems in the daily living situations of the patients. So you have to take this seriously. And besides that, when you have symptoms, recurrent symptoms, that could mean that the initial rupture could be even bigger with time. And that has been demonstrated also by this article and many others, that when you have symptoms, you can have the tear active and progressive. The natural history of asymptomatic rotator cuff tears has been a matter of debate, but probably we will agree that when you have symptoms, when you don't have symptoms, the tears could increase, but in a less proportion than when you do have symptoms. These proportions has been in this article calculated in 36% of these patients. With time, in 3 years of follow-up, they progress. But more than 60% of the patients didn't progress. So it's important to know that. And probably this is the main topic of this talk. Why not operate on all tears? I will have 2 slides for each of these reasons that I think are important to not operate in everybody. First, the prevalence. We all know that it's very common to have a rotator cuff tears when you are 50. And when you are 60, even better, even more, and so on. This graphic is very clear. You are familiar with this. I think you can see here the arrow. 30% of the people in the 60s have rotator cuff tears, 40% of the people in the 70s, and more than 60% of the people in the 80s. So as David Ring has said, this could be considered a common aspect of normal human aging. So you don't have to operate 30% of the world population when they are in their 60s. We wouldn't have time to do that, even with all the good surgeons that are around. The progression is important. You have to be careful with that. Of course, rotator cuff tears can progress, but not at the same rate. It is important, this article from Japan, they take in considerations two things. One, the size of the rotator cuff tear in this coronal view, and then the location of the tear in this sagittal view. When you have sizes between more than 1 centimeter and less than 3 centimeters, the progression of the tear is very clear. Is not as clear when you have small tears or when you have big tears that probably you the progression is less rapid. The superior aspect, that is the more common aspect of the rotator cuff tear, is another place where the rotator cuff progress more. So it is important to know in your first MRI the location and the size of the tear to have an idea of how they are going to progress. Some people say if you don't operate a rotator cuff tear early, you are going to have a rotator cuff arthropathy in the future. That's not true. The rotator cuff arthropathy is a reality, but it's not for everybody. It is clear that you can have small glenohumeral changes, arthritic patients changes, but minimal. And this is a follow-up of 8 years, but you can have articles with more follow-up where the arthritic changes are minimal. Of course, some patients, especially the ones with massive rotator cuffs, will develop rotator cuff arthropathy, but by any means, this is the rule. Very important. Daniel showed this in his talk. He showed very graphic and terrible examples of metastases or tuberculosis, and he's true in that. But these are the more common source of pain in rotator cuff, and you are not going to help the patient operating on him if he has any of this. So you have to be careful. The patient could have a rotator cuff and some of these situations, and the pain could be from these situations, not for the rotator cuff. You have to be very careful of that. And there is no correct correlation or clear correlation between the size or the severity of the cuff tear and the symptoms. You have to be careful of that also. Daniel showed an example of that. The mental health every day is more important. Some patients relate to his shoulder because of mental problems. Of course, nobody is saying that the rotator cuff pain is a mental problem. No, but there are patients in which you have to be careful with his mental status before operating on them, because you can do the best surgery, but the patients could continue with pain. 2 more slides for talking about the non-surgical treatment. As Daniel, I was with Rockwood also, and he was a champion of what he called the ortho therapy. Orthotherapy is the therapy done by the patient himself, and a lot of patients did much better with therapy before doing surgery. Some of them never needed surgery. This is a very interesting comparison. This Jay Chulyo, Daniel, you remember him? He was at your meeting in Buenos Aires, wonderful person. And he compared the patients with and without surgery, but very important, after recommendation of surgical repair. Some of his patients, after the recommendation, decided not to have the operation, and they follow them. So they have the same indications for surgery at the beginning, but as you can see here, surgery and non-surgery patients, after, I think, 2 years of follow-up, did similarly in all these scores, constant, UCLA, shoulder simple test, etc. They did similarly. So really, with time, the surgery in this cohort was not as better as we think surgery is. Surgery is not perfect. This is an article from Madsen. And Madsen many times says very interesting things. He has this graphic in his article. As you can see, there has been an explosion of articles about rotator cuff tears after 2000 and especially after 2005. But in spite of this explosion of articles, the post-op score here in purple has been the same. So no matter how many articles you write, no matter how many patients you operate, the scores are similar. So, and why is similar? Because we, as Daniel said, we are facing a biological problem. So you can do the best surgery, but the biology, you cannot change the biology, and probably that's why the post-op score is similar, even with thousands and thousands of operations, now much more than before. Finally, not everybody wants surgery. That's important. This is from Zurich, Christian Gerber and his colleagues, and he saw people that decided not to have surgery for many reasons. These are some of the reasons. And after they decided not to have surgery, they went fairly well. As you say here, patient satisfaction and the size of the tear was not very big. These were the reasons for the patients not to have surgery. Some of them improved, some of them have economic problems, or they didn't want to have long rehab after surgery, etc. But they didn't do so bad when they refused to have surgery. So these are reasons for not to operate. You can be, you don't have to be disturbed by that, because if we operate the patients that I said in the beginning, we will have plenty of patients to operate. The situation is not that we are not going to have patients anymore. The situation is that we have to operate the ones who really need the operations. And why? And I'm finishing in 2 slides. Because we all agree that the benefit of a surgery is to change the situation of a patient. If the patient doesn't have symptoms or doesn't want to have an operation, or we don't give him the opportunity of a non-operative treatment, etc., the benefit will be questioned, but the risk remains the same. The appreciation of the patient of a surgery is easy when the patient has pain and cannot sleep and his daily activities are impaired. But if the patient doesn't have many symptoms, he will not appreciate the result, and he will blame you for pain and problems after surgery. The complications, if you have a complication with a patient with all the indications, you don't have a problem. If you have a complication in a patient that didn't need the surgery in the first place, you will be in great trouble. So this is the final slide. I will go back to these recommendations: acute ruptures, and for the last 2, persistence or recurrence of symptoms or increasing tear size, you have to do a follow-up of your patients. That's the key here. You have to follow up your patients. Even in patients that don't have symptoms, you should have an MRI 1 or 2 years after the first consultation. And if the tear size is increasing, you should think in operate even with no symptoms. So this, I hope this will be helpful for you. Thank you very much.
Thank you very much, Dr. Juan Carlos. That was a very, very much needed presentation. A good clinician should know when you should not operate before you know when you should operate. Thank you very much for pointing out the limitations of surgical fixation of rotator cuff. However, we also have the indications that are very clear, as you pointed out in the last slide. So I hope to have more and more discussions on the indications in the discussion session. I now kindly request Dr. Juan Pablo Simone to go ahead with your presentation of mini open rotator cuff repair.
Thank you, Sassi. Thank you for your kind invitation. Can you see my screen okay?
Yes, clear.
Thank you. Okay, now I will follow up with two outstanding talks. They were really very good. This is a bit more of an objective lecture. So we know that management of rotator cuff pathology is very controversial, as we just heard. Yes, we have to make a lot of decisions. Who needs the repair? What approach do we need? How to fix it? What is the best post-operative protocol? But right now, what we do know is that surgery for rotator cuffs, that's when we decide to do surgery, our goal is to decrease pain, improve function and strength, and to avoid tear progression. And we can do that with an anatomic, stable, and tension-free repair. That is our goal once we choose surgery for our patients. So the goal of this presentation is just to review the mini open surgical technique. It's a technique that I find very useful. I am not biased because I don't do it always. I do mini open and I do arthroscopic. And I would like to review the results and benefits that we have with this technique. So I will start with a case example. This is a short video of a technique for a perfect case for this mini open technique. This is a complete tear of the supraspinatus tear with the retraction up to the humeral head. We have the patient in the beach chair position, and we will do an approach just along the anterior border of the acromion that usually fits or stands out nicely in the supraspinatus footprint. We will do a deltoid split, find the tear, prepare the footprint, and do a repair of the supraspinatus tear. In this case, we're going to do 2 rows of sutures like transosseous equivalent. So we do the superficial skin incision. Then we go ahead and find the deltoid fascia. So this very small incision, it's usually 3 centimeters long. Then we do the split of the supraspinatus tendon, the bursectomy. Remember always the split, it never has to go 5 centimeters distal to the acromion. Now we can find the tendon. In a lot of cases, it will be a free tendon tear. We can do the inspection. I always like to put a suture around this tendon so we can have better control of it. Now we're inspecting the rest of rotator cuff with rotation and retraction, and we can see that the subscapularis and infraspinatus are fine. Now we're preparing the footprint. So these are all the very same steps that we do for either full open surgery or arthroscopic surgery. After we do the footprint, we can see that the tendon will go nicely in the footprint and without any tension. We will place the medial anchors. I like to place the medial anchors close to the cartilage area, so I am sure I won't have a lot of tension in my repair. If I have the arthroscopic suture passing instruments, I find them to be very fast, especially for mini open technique, but you can also use a free needle. That's no problem, whatever instrumentation you have. If you have a free needle, remember that the radius of curvature has to be small because the acromion will be on your way. Like here, we're using a free needle. So both ways you can do it perfectly fine. Then we go ahead and tie the sutures. This is the medial row fixation. That's the one that will make the tendon go close to the medial side of the footprint. And we can have a discussion if a single row, double row is better. I like for these young and active patients to do a double row procedure so there is a better contact surface of the tendon. And I have the impression that I can give them earlier rehabilitation with a strong fixation. So this is the double row knotless sutures, and it looks like a transosseous equivalent in this fashion. And now we have a very secure fixation without tension of the supraspinatus tear, and it's very anatomic. So we then just close the deltoid split and close the wound by layers. So this is only a surgical demonstration of an easy case, of course, no? But I wanted you to see the step-by-step procedure. So let's see a bit of publications. What are the functional results of a mini open technique? So this is a nice study. It compares mini open versus arthroscopic repair of complete supraspinatus tear, patella type 2. So it's just like the one I showed you with double row fixation. And they have seen that there is less surgical time with mini open technique. It can go really fast. No difference in added size of the surgical incision when they add all the incisions of the arthroscopic procedure versus the mini open, it's exactly the same. And they found less cost with mini open technique. And they also find that there is better functional score in the first 6 months with arthroscopy, and then the functional scores are the same. Another similar result, mini open with assisted arthroscopy, that's the assisted subacromially compression and inspection of the joint, versus full arthroscopic repair, small to medium-sized tears like the one I showed you, and they see that there is faster recovery to daily activities with full arthroscopic 10 versus 12 weeks, but the same overall functional results in the long term. Another study, mini open versus full arthroscopic, complete supraspinatus and infraspinatus tear, and we can see that there is a very similar pattern of the results that we have. There is less surgical time with mini open, less pain, and better functional score initially with full arthroscopic repair, but the same result 6 months post-op. Now, what about the costs? So we've already seen a bit about the costs. Usually, there's less surgical time with mini open technique, same functional results again, but when we specifically study the costs, there is less cost with open technique due to arthroscopic material because of the disposable instruments that we have to use for arthroscopy. Again, another study talking about costs, and I think there's no discussion that mini open repair is more cost effective compared to arthroscopic procedures. So if we want to reduce costs at our institutions, mini open repair might be the way to go. What about tendon integrity? There are not a lot of publications about tendon integrity or so who does better biologically. This is a study that's comparing mini open repairs, 22 patients versus full arthroscopic. It's a bit biased, the study, because there are different types of tears. Mini open had 45%, arthroscopic 38% with 2 or more affected. Then they did ultrasound assessment for tendon integrity. And surprisingly, they found that mini open technique, 91% of the cases had healed, and arthroscopic 60% had an intact repair. But overall, despite this difference, there was no difference in pain or patient satisfaction in the long-term outcome. Now, if the tears are large or massive tears, well, then the same thing happens with every technique. Integrity is not perfect. There is a recurrent effect in about 50% of the cases and sometimes more. But again, good and functional outcomes can be expected in 93% of the cases. And we have also learned from a lot of different studies, not only this one, that patients with recurrent defects are on average 15 years older than those with intact repairs. So just for final considerations, I don't think one technique is better than the other. They have advantages and disadvantages, but what we have to know is that functional results and patient satisfactions in the long term will be exactly the same. Surgical time is less with a mini open and arthroscopic technique. Surgical cost is less a mini open, but patients with arthroscopic technique might have earlier recovery, and that has, of course, a good social cost as well. So thank you for your time, and let's hope for nice discussion.
Thank you, Dr. John. Simone, that was a beautiful presentation and a very clear distinction between the benefits and the limitations of arthroscopic and mini open rotator cuff repairs. And your video presentation also was very useful. Thank you very much. I now request Dr. Diego Gomez to make his presentation on arthroscopic rotator cuff repair. Over to Dr. Diago.
Hello, can you hear me?
Yeah, it's clear.
Okay, sorry, I was having a problem with the video.
No,
okay, well, amazing presentations by all the speakers. It is wonderful for us, for the young generation, to listen to the voice of wisdom when to do a surgery and when not to do it. Is really interesting for us. And I would like to thank you, Sassy and Daniel, for the invitation. It's a pleasure for me to be a part of this webinar. And my talk will be like a complement of what has already been said, because as we all know, the surgical technique of rotator cuff repair has evolved over the years, not necessarily getting better, but evolved, changing. However, the goal continues to be the same. We want to have a complete healing of the tendon without suffering any complications. Considering the extensive information on this topic, we're going to focus to concentrate only on degenerative tears of the posterior superior cuff. And I will not speak about results or indication. Those items have been already well addressed. So my objective is to speak about these 5 fundamental technique issues to obtain a successful surgical result. So in the last decade, there has been progress in the field of anatomy. Mochizuki and Sugaya showed us that our shoulders had changed. The footprint of the supraspinatus turned to be much smaller than previously described. And on the other hand, the infraspinatus was proven to cover a substantial amount of greater tuberosity. In a similar manner, the thickness of the rotator cuff footprint has been overestimated, having a lack of discrimination between the cuff insertion and the superior capsule. So now it has been proved that the attachment of the superior capsule on the humerus covers a substantial area of the greater tuberosity, reaching up to 9 millimeters at the level of the posterior rotator cable. This leaves even a smaller area for the supraspinatus and infraspinatus tendon. So in cadaveric dissections done in Argentina as well, we have observed the same findings as Sugaya teams, considering the wide insertion of the infraspinatus and the significant thickness of the superior capsule. Going to step number 2, both the lateral, the cubitus, and the big chair positions are reliable to make almost all procedures in shoulder surgery, considering cuff and stability. Our preference for big chair is based on training and habits most of all. It has many advantages, like the fact that we are operating in anatomical position. It allows you to do some specific examination of the shoulder under anesthesia. And moreover, give you access to the anterior part of the shoulder if you have to do anterior procedures. And if you are starting with your learning curve and you need to convert to open surgery, you can do it without the need to change your position. Of course, a requirement in arthroscopy is to see. And if we do not control certain factors, we may have this image on the television. And in Argentina, we say that this is the Japanese flag. So these are some concerns we may have, and it's highly recommended to maintain the hypotensive anesthesia. And for that, the advisable value of mean anterior pressure is 60. The systolic blood pressure is less than 100, and the differences between the systolic blood pressure at the water pump should be less than 50 millimeters. So if we take a look at the monitor, we are having those values. So we are happy we can see the screen. We additionally use tranexamic acid to decrease the bleeding in the surgical field, so we can see even better. But with all these conditions, at least in Argentina, we can make the anesthesiologist very, very nervous. Why? Because we have the potential danger of a cerebral ischemia. Of course, it's one of the biggest disadvantages of the big chair position. the risk of hypotension and bradycardia, causing cardiovascular complications. Assuming that the upright position decreases the venous return and the cerebral perfusion, we use these very, very lazy big chair positions. If you take a look, you see that the patient is almost lying down, is not even seated. That gets a much better venous return and a better cardiac preload. We also use the near-infrared spectroscopy, that is a non-invasive method for measuring oxygenated hemoglobin in the brain. That way, it allows us a sharp control of the pressure with control of cerebral oxygenation. So regarding step number 3, the portals, the classic portals, with these 4 typical portals, we can do a lot of things. The posterior one is at the level of the soft point in the junction of the supraspinatus and infraspinatus. The anterior portal almost at the tip of the coracoid process, which allows you to do a subscapularis and a biceps treatment. And then the lateral portals should be done 1 or 2 centimeters under the acromion. The only concern is leaving a space of 2 fingers, and this is adequate, it's a good distance to be able to triangulate without problems. So in this video, and I hope it runs properly through internet, we can see through the posterior portal a severe degenerative biceps and a grade 2 supraspinatus tear, and from a mediolateral portal we can do the tenotomy, and we can do also the decortication of the footprint. After that we go subacromial, we release the adhesions and the bursa, and we can mobilize a little bit the tendon just to take a notion if it can reduce without tension to the footprint. So if you pay attention, we have done all this only with 2 small portals, and I think that's a good thing in this kind of procedures. But of course, you should do as many portals as needed, and one we almost every surgery do is the superior portal to get a good attack for the anchor placement. This portal should be done in a way that you get a 45 degrees inclination, so you are in the good position for the dead man angle described by Stephen Berger. Going to identifying the tear patterns, we will start with partial tear. With A1, A2, and B1 from Ellman partial tear classification, we only do a debridement. But in some cases, we still do an acromioplasty. I agree with Dr. Moya. Everything he said about acromioplasty is true. But for us, in some scenarios, it still makes sense to do an acromioplasty, especially when you have a bursal side tear and when you have a patient with a really tightened subacromial space. So you need to open it a little bit more to have more space to work. But of course, we do not do it systematically. And another additional advantage we have with arthroscopy, you can also treat the AC shunt in case it is necessary. And you can do all that with the same approaches, the same portals I told you before. Finally, when you have an A3, B2, or B3 lesion, you can do a transtendinous repair, but this has some risk because you can over-tension the superficial layer, and this can be detrimental for the healing and also very painful for the patient. So in our hands, we prefer to do a takedown and repair. We put a needle in the anterolateral portal to localize the tear, because this is difficult to see from the subacromial space. So once we do this, we go with the shaver or the radiofrequency, and we complete the tear, and we do the decortication of the greater tuberosity. And once you have that done, the rest is just performing a double row transosseous equivalent repair, as Juan Pablo Simone showed. Considering the very well-known classification from Burkhardt and Debson. This classification, I like it because it's easy to use it and to apply it to do a good reconstruction and to a good repair. So each of these lesions should be addressed in a different way with a different strategy. So if you have this classification as a guide, you may be able to perform an standardized low tension repair. So we will start with the easiest one. The crescent is the most common. It's almost 40%, sorry, of full thickness calf tears. So it is a direct avulsion from the greater tuberosity, and it has an excellent medial to lateral mobility of the tear, allowing a tension-free repair directly to the footprint. In these cases, we do a double row, like a suture bridge, but you may be able to repair it with any configuration. We use this one. We have some evidence to support it, but as has been said, it's not mandatory to do a double row. You can still do a single row, or you can do transosseous repair. So once we have finished the repair, the reconstruction, you can see a proper closure. And we will advance with a much more difficult scenario. This is the longitudinal pattern where you can have a U shape or an L shape. And here the key point is to simplify the lesion. You need to do side-to-side sutures in order to finalize with a more simple tear where you can do the same we have already shown. So in this video, I hope you can appreciate it's an L-shaped tear which has both transverse and longitudinal components. The apex of the V or the U extends much more farther medially towards the glenoid. So the medial to lateral mobility is limited, so you need to bring to the front the tear that is in the back. And for this, we use PDS sutures. I know Daniel Moyer loves these sutures, and for us, they work really well in this kind of lesions because you can close in a side-to-side Martian conversions manner without using any kind of anchors. And you will see with only two simple, really simple to do knots, you can close the anterior gap and you can have a simple crescent tear in the side. So moving on, we have some lesions, some tears that they are massive, contracted, and non-fully repairable. In these patients, one practical solution is to do a superior capsular repair with the long head of the biceps. This is described by Johannes Barth, and of course, this is necessary to have some training to do it, but if you have the biceps available, it's not that difficult. And once you do it, what you do after you fix the biceps is to bring the posterior calf to the front and again do side-to-side sutures and repair the rest with a double row transosseous equivalent repair. A lot has been said about the biology, and I agree. I think the solution is not in the materials, it's not in the devices, but there is a trend lately for coil-type anchors, which for the moment have many biomechanical and biological advantages. For example, it should be or it can have a greater healing. This is potential, but with some proven biologic facts. The crimson duvet effect, because these anchors are open, so a lot of bone marrow elements comes out through these holes. And this has been proven by Jorge Chala, who reported bigger concentrations of growing factors after putting these kind of anchors. They also have a better ingrowth if you compare with regular anchors, and this has already been proved by Chala with the CT scan at 6 months post-op. And by another author in 2010, a higher pull-out of strength, especially in osteoporotic bone. Finally, considering the fact that the sutures are abrasive enough to hurt our hands with gloves when we do a knot, we should consider what happened with the fragile tendon that is already weakened and it's under a lot of pressure when we do a repair. So If we pay attention, we have some benefits in using a tape against the suture. It has better footprint contact and is less aggressive fundamentally. So to conclude, you need to understand the anatomy to treat this pathology. You should master one position and one technique in order to have reproducible results, and you should identify the tear pattern and perform a simple repair in this pathology. And again, try to do it as biological as possible. Thanks a lot.
Thank you very much, Dr. Diago. That was a very crisp presentation on the principles of arthroscopy cuff repair, and also the advances and also situations when you can't do a repair and the options available for that. I kindly request Dr. Radhakant Pandey and Dr. Vivek Pandey to take over the session to moderate and share your experience and ask your questions.
I think what we'll do is me and Vivek will focus questions on each speaker so that everybody gets a chance to express.
Sure, sir.
So is Vivek listening?
Yes, sir.
Is that okay? So
yeah,
you can go speaker to speaker rather than...
Yeah, I think that's much better.
So do you have any questions for Dr. Moya?
Yes.
I ask?
So Daniel, thank you for an excellent presentation and your summary, what you gave with your vast experience. So I have a couple of questions, one based on the acromioplasty and second would be on acromiohumeral interval. So let me start with acromioplasty, and for the benefit of all those people who are listening to that. So you went from the lateral acromioplasty, then two-stage, and then compulsory acromioplasty to now plus minus. So what is your today indication for acromioplasty? When do you do?
Well, I agree with Diego. I think that in medicine, there are two words that should be forbidden: always and never. So sometimes we see such a big osteophyte at the acromion that would be impossible not to perform acromioplasty. So, but if I compare how many patients I face today with that size of acromion, comparing with the patients I saw in the beginning 30 years ago, the amount of patients with big osteophytes is much lower because generally we perform the surgery earlier in these cases. So not so many cases have a natural evolution of the situation. But in some cases, we find such a big acromion that it is necessary. If we should give the audience an option of when to do that, Rockwood used to say that performing an AP view X-ray with 30 degrees of caudal tilt, you make a line in the caudal end of the clavicle, of the caudal wall of the clavicle, and all the acromion that is behind that should be removed. That was his practical advice about how to calculate how much to remove.
Okay, so basically, if we say it's something like, the type 2 acromion sometimes have spur because type 3 originally is quite rare. So it all depends upon the radiological finding. If you have a large spur or really an osteophyte, you would like to remove. Otherwise, in general, as you said, you are not going to touch the native normal anatomy. Am I correct?
Yes. So I spoke about the peak and decline because we were performing acromioplasty in all our cases, besides the size and the morphology of the acromion. It was a part of the technical procedure, the acromioplasty.
True. Like what Neil said, it has to be done as a part of the procedure.
Yes.
And second,
actually, we in Leicester, I
how-
mean, I published a scoring system. It's published in Journal of Shoulder and Elbow Surgery, the American one. I think it's 2012. So I published a scoring system, the point of 6, which included X-ray and response to steroid and how long the symptoms was and whether they had physiotherapy. And if they had 6 out of 6, and if you did an acromioplasty, they'll do well. But if they had only 3 out of 6, they don't do, there's no change.
Mhm.
So there is a scoring system which I had published almost 10 years ago.
on a lighter note, you should have said it as a Leicester score or a Pandey score. Then all of us would have remembered.
Yeah, it is a Pandey score, yes.
Good.
Journal of
Going to
Shoulder
look
Elbow
up for it.
Surgery. Unfortunately, the popularity of acromioplasty is going down after the Oxford study by Andrew Carr, in which they looked at acromioplasty, and they thought that doing an acromioplasty is essentially just a placebo effect. But that remains to be seen. So can I ask, sorry, Vivek, you carry on.
No, I think Yuan wanted to say something. Juan Carlos.
Yes, thank you. Yes, I would like to say two things. One, I really don't believe in the classification of grade 1, grade 2, and grade 3 acromion by Bigliani, because I think that the problem is not that the acromion goes down in the subacromial space, but go in the direction of the the coracoacromial ligament. It's an enthesopathy. It's the rotator cuff insufficiency makes the head goes up, the head up, traction, the insertion of the acromiocoracoid ligament, and the osteophyte is going in the direction of the ligament, no down. So I don't use the Bigliani classification. Yeah. That would be the first thing.
Yeah,
and the
I
second,
also don't use. So can I ask another question to Dr. Moya? I think what you started your talk with two excellent cases which demonstrate shoulder is not only about rotator cuff and joint. It's a very common place for tumors, both primary and secondary, and all sorts of tumors. And there is this trend of orthopedic surgeons doing their own ultrasound scans, and they forget that an X-ray is, if you're doing a scan, an X-ray is extremely important because an X-ray tells you a lot more than an ultrasound scan. That is why in my department, we do an MRI scan because that combines the X-ray and ultrasound scan. So what is your thoughts about doing an X-ray? Are we slowly sort of forgetting the simple workhorse of an orthopedic surgeon, the good old X-ray in shoulder surgery?
Well, Rockwood used to say that you can perform most of the diagnosis on shoulder pathology, including an X-ray, a physical examination, and just talking with the patient. So I think that is the first step. And then I generally include an MRI. If the patient has problems or dislikes the option of an MRI, I refer the patient for an ultrasound to a very specific medical radiologist. But I think that because not all of them have enough skills to perform a good ultrasound exploration, I think that we will face much more of the kind of patients I show you in the future, because what is even worse, and I don't want anyone to get mad at me with this, but there are many physiotherapists performing ultrasound explorations, and they say that they are using that just to localize the place where they should work, and I would agree with that. But the problem is that many of them get tempted to play doctor, and they are not allowed, at least in our laws, to ask for an X-ray, so they will never have an X-ray. Some patients are going just to the physiotherapist, and they get an ultrasound exploration and a diagnosis of a tendon tear, but perhaps beyond that, there is a metastasis. So we should be
arthritis.
Yes, yes. And what is even worse is that from the literature, there are many papers that are speaking as a diagnosis about shoulder pain or subacromial pain. And that for me is crazy. There are more than 90 different pathologies that could give pain at the level of the shoulder.
Thank you. So Vivek, shall we go to Dr. Gonzalez now?
Rather, sir, one more.
Yeah.
What's your thought about the AHI? How much importance you give to the acromiohumeral interval when you see it on a plain X-ray? Because we have recently concluded our work, a long-term work on this AHI, and somehow due to some reason the publication is halted. But my thoughts on AHI is, I mean, initially we wanted to see, okay, how many tendons when they are torn, you know, the AHI is narrowed less than 6, and that is always 2 tendons. So if you see less than 6 in a standing AP view of the shoulder X-ray, it gives an impression that the 2 tendons are torn. But MRI wise, they are not very sure, because MRI, when you do it's always in the supine position and shoulders are slightly up. So that may narrow the interval. So that's why one of your X-ray, when it shows a better AHI on the X-ray, whereas reduced AHI on MRI. But do you really give too much of importance to AHI regarding the repairability or not? Or you take chronicity in the, conclusion?
You know, I always say that when you are making a diagnosis or deciding a treatment, it's like making up a puzzle, and you have different pieces, and in different patients, perhaps one piece is bigger than another. And this is just one more piece of that puzzle. And one of our heroes on rotator cuff repair is Christian Gerber. No one would discuss that. But if we go back to one of his papers, he defined the HA difference and was considering many options or many variables to make the decision. But even with that, he got around 30% of retears or non-healing. So this can show us that it is very difficult, because in fact, what we are seeing, speaking about retraction, speaking about the shape of the muscle belly, HA difference, space, they are not a direct idea of the biology of the tendon. In that case, we are speaking about repairability, but we can repair, we can do the mechanical gesture of fixing the tendon back, but we don't know if it is going to heal or not.
True.
That's the biological response. And I think there is no correlation between the HA space and the biological response.
Very
okay.
true.
Thank you. Shall we go to Dr. Gonzalez now? Hello.
Yes, please.
So Dr.
Yes,
Gonzalez, you'll be glad to know that the first thing I tell my registrar or resident and a fellow is, not all cuff tears need repair. That's the first thing I tell them. But I want to ask you about acute tears. From your talk, it looked as if most acute tears or all acute tears you would like to repair. Now, the problem in UK we are facing is our population is getting very old. And all the people who are 70, 75, in the winter, there is ice, they will slip, they will fall, and they dislocate their shoulder or a shoulder injury, and many of them come with acute tears. So we are doing, there is going to be a study in which the randomized control trial in which all the acute tears will go, one group will be, they'll repair immediately, another one, all of them will have physiotherapy and rehabilitation. So that result is still going on. Do you think all acute tears need to be repaired? But because, you know, this population of 70, I always send them for physio, and many of them do get better, even if they have an acute tear.
No, I think you raise a very nice point here. It is different to have an acute care when you are young. Young, I mean below 60, than when you are 70 or more. Could be probably between 60 and 70 is a gray zone, but it is very difficult to diagnose a unique acute tear in a person who is 70 or older, because as you agree and as you saw in my presentation, 30% of the people over 60 and 40% of the people over 70 have already, just for prevalence, regular prevalence, a rotator cuff tear. So you can have an acute over a chronic problem in your shoulder. So how do you manage that, and how you distinguish between a clear acute and acute over chronic? It is difficult, but you have two or three things. Of course, the history, the clinical history, the pain before the fall, symptoms before the fall are very common in these patients. In the MRI, you can see atrophy or fatty infiltration in the sagittal view. And when you have a suspicion that that patient had before tear, I wouldn't treat him as an acute tear. I would wait and do what you said, do physical therapy in this older population. I think you have a very good point there.
Okay. Sorry, Dr. Moya wants to say something.
Yes, I completely agree. And I want to point out that perhaps the only situation in which there is no discussion to perform the repair in an older patient is when the rotator cuff tear is the result of an acute glenohumeral dislocation. In those cases, if we do not repair or attempt to repair the rotator cuff, the incidence of redislocation is higher, much higher.
But do you wait for them to have the redislocation?
No.
Or you repair it straight away?
I repair it straight away.
That is interesting. We send everybody for physiotherapy and make a decision at 6 to 8 weeks to see if they are progressing at physio, will continue. But if they are unstable or they redislocate, then there is no question. But not everybody redislocates, because it depends on how bad the tear is.
No, I would do that if there is not tear of the rotator cuff, with no doubt, and most of them will never dislocate again if they are older people. But if there is a tear of the rotator cuff, I think that the chance of redislocation is very high.
Okay. Vivek, you want to ask anything to Dr. Gonzalez?
Yeah, Dr. Carlos, do you also, sorry, regarding this acute tears? So if we look at the Burkhart's theory, where he says the cable is intact, you know, the front and the back is intact. So if you have a patient who had a fall and he comes to you with a pseudoparalytic shoulder, acute shoulder, you take an MRI where it shows, okay, the cables in the front and back are fine, only the middle part is intact. Vis-a-vis a patient whose whole front, middle, back, everything is gone. Will you treat those two patients separately? Like one with the cable intact, you say, okay, you try physio as Dr. Rathakant was trying to say. And the second who has got the complete separation, you know, from the front to back, you say, likely that he may not respond, you would subject him to surgery. Does that, you take those things in account?
I take that in account for the diagnosis and for the evaluation of the images, but I don't take that in account for the decision.
Okay.
You probably are right. If you have the cable, the intact cable, probably that patient is going to go better without surgery. But if we are talking about younger patients, 60 or less, and a real acute rupture, I would operate both cases acutely, because it's difficult for me to rely in the intact cable situation just in that. I would prefer to be more sure and do an operation on those patients. It is an important fact, and as you said, it has better prognosis when you have the intact cable. But I would prefer not to let that to don't have any chance of a bad result. So I would prefer to do a surgery in both.
So in practice, I follow what you do. It was a theoretical question. So in practice, if a tear is more than a centimeter, irrespective whether it has involved the front or back or not, I will operate. If it is less than a centimeter, traumatic, somewhere in the middle third, then I would, discuss with him. I'll give him a chance, and it's okay. You do the rehab and see. Well, let's see at 6 weeks time. But by and large, anything bigger than the small tear, then traumatic and no atrophy, then better to repair. I don't know why. I mean, this is the practice we follow. Theory is different.
Sure, I agree. Even if you have an acute tear of 1 centimeter or less, it is true that when you have a small tear, the possibility of that tear to progress is less. That's completely true. But when you have an acute tear, and you probably agree with this, the patients, since the patients didn't have the chance to have a chronic possibility of getting better because of the own capacity of the shoulder to go better. When you have a chronic tear, you have the chronic tear, and you have the possibility, your body have the possibility to build some compensation situation. But when you have an acute tear, the compensation is not easy for the body, even if the tear is small. So you have much more symptoms, much more difficulty when you have an acute tear. And I would try to operate all acute tears in the younger population. Of course, there are some exceptions. If the tear is 1 millimeter or 2 millimeters, you can wait. But I would say that it would be wise to operate acute tears in the younger population.
I will.
Doctor, can you also tell me if it's a 55-year-old chap with a full thickness cuff tear, not acute, chronic tear, he's got some pain. How would you deal with that patient who's below 55, say 53-year-old, 2 centimeter tear, painful shoulder, no weakness, going his job, but he came to you with painful shoulder. You've done a scan and it shows a 2 centimeter chronic tear. What would you do with him?
Yeah, I would operate that patient. The younger the patient, the more useful the surgery. And
would you not do physiotherapy at all?
If the patient goes to my clinic for the first time with a couple of weeks or a few months of symptoms, I would do physical therapy, but I will follow that patient very closely, because as you know, the younger the patient, the more symptoms he's going to have. And when the patient have symptoms, as I said in my talk, persistence of symptoms is an important thing, because symptoms are associated with progress of the tear. So I would not operate a 55 person if the patient doesn't have symptoms. I would wait, and I would have another MRI 1 year or 2 years after the first consultation. And if the tear increases in size, I would operate. But if the patient has symptoms,
if he's still asymptomatic, but the scan shows the tear has become bigger, but he remains asymptomatic, would you still operate?
yes, I would operate that patient, because it's very clear for me that in that specific patient, even with no symptoms, the tear is increasing in size. And I would fear that if I wait 2 or 3 years more, the size will be so big that it is going to be difficult to operate, and then you will have a problem. So yes, I will do a follow-up, and I will operate if the size is bigger.
Good. Right. So shall we move to Simone, Vivek? Dr. Simone?
Yeah, this last point, Dr. Pandey, what you raised, let's have the opinion of everybody. So a patient who came with a specific size of tear, 2 centimeter, Dr. Carlos started him on rehabilitation. He started doing better. But since he was relatively young, he was followed up with different MRIs at 6 months and 1 year. And each time the MRI, though he remained asymptomatic, but because he was young, he wanted to do a repeat MRI. And on MRI, the tear was progressing. So Daniel, Pablo, Diego, would you operate or would you not operate? Now asymptomatic, but tear size is gradually increasing. So I would operate, because as very, very clearly Carlos said, he's now 55, let's say 56. And in 5 years, 6 years time, he might one day become completely, decompensated. Now he's compensating. It's like a compensated cuff tear. And that time it's difficult to, repair it completely. So I would agree that even though he has become asymptomatic, I would operate because he's young. So Daniel, Pablo, and Diego, would you or would you not?
I don't know if you can see the knife.
Yeah, it's scary.
Okay.
Oh, yes. I am 59 now. If I have a 2 centimeters rotator cuff tear, please operate on me, because I know that I am buying a problem for the future. So perhaps now I have not big pain, but most of these patients get used to the pain and get used to the limitation, and they are coming and going. So I will feel like sweeping the dust under the carpet, But I completely agree with Juan Carlos that if a patient is saying I have no pain, no one will operate the patient if there is no pain at all. But I take a long time to discuss with the patient and give the patient a good explanation about the situation and about the future.
True. Pablo, will you operate or not?
Yes, I would probably advise for surgery, but I would take a long time telling me what my worries are. And my big worry is that the patient might feel worse if I do surgery for him because he's asymptomatic. Correct. But thinking about his future and trying to stop a possible problem.
Okay. Diego?
Well, I agree with what has been said. Of course, I hate to do a surgery in a patient without symptoms. It's horrible. And it's a really difficult match to win because that patient will be in pain for a couple of months at least. And it's really important for him to understand why is the surgery being done, thinking in many years in advance, not thinking in the summer or next year. So not the ideal situation, but I would advise surgery, hopefully when he has a little bit of pain. Maybe if we are lucky, he's in pain in the next month, and that's the best moment.
Because I think the people who have pain and difficulty in elevation vis-a-vis only pain, the pain and difficulty in elevation, they do much better because they regain their movement if you have done a good job. And the people who have only pain, unless and until the VAS score really comes down from 8 to 2, if it is just from 4 to 3 or 4 to 2, they keep on scratching you. So I think that's a good thing which Diego said. It's better to operate when they have little pain rather than have no pain.
I think another thing important is the weakness. So if you do the Jobs test and you can demonstrate to them that this shoulder, especially if it's the dominant shoulder, is significantly weaker than the other side. Even if they did not have pain, they understand that there is a problem with this shoulder. And they have weakness now, which may progress with time. And most of the older people, they're not too worried about the pain. They are worried about their independence. They want to do things on their own. They don't want to ask their sons and daughters to help them. So if you show them they are significantly weak on one side and this weakness may progress, they understand, they might agree to have surgery. I mean, this is just a trick I learned from my boss, Steve Copeland, many years ago.
Very true.
So next, we shall ask
I'm sorry. I think these are very beautiful points, but I think the patient's preference also varies based on the location. I think the independence, the feeling of independence, is an important factor in the UK, but possibly it is not an important factor in India. I mean, as far as the patient's consideration is concerned.
That is also changing.
Yeah.
Okay, shall we ask Dr. Simone some questions? Yeah. Dr. Simone, I hope I'm not coming across as showing off. I also wrote a paper about comparing arthroscopic cuff repair with open cuff repair in Journal of Shoulder. We looked at cost effectiveness of one over the other. And when we did an open repair, we did not use an anchor. So our cost went right down because anchor is quite an expensive thing. And if you use 3 anchors, that adds about $700-800 to the procedure. So the two things here, in UK, when we say mini open cuff repair, it means that you do an arthroscopy first and then do an open repair. Is that what you mean by mini open repair, or you don't do an arthroscopy first?
You can do both ways. I would say 90% of the times you would do an arthroscopy just to make sure you can do a diagnostic arthroscopy, subacromial decompression, and then add a mini open technique. Mm-hmm. For the patient I showed in the video, we just did a mini open technique because it was very clear to us what she had, and she had fibrosis pulmonary problems. So our anesthesia wanted us to do surgery as fast as we could. But I would say 90% of the time you would do a subacromial decompression and arthroscopic inspection of the joint to see if there is anything else you need to be done. Having said that, that also adds more surgical time and more costs. So yes,
in India, cost is an important factor, and I'm sure it's an important factor in the rural Argentina. Buenos Aires, everybody is very rich. If you go to
except shoulder surgeons.
If you go to rural India, doing an arthroscopy adds to the cost. So if you have a cuff tear, the paper I published, we did an open repair, not an arthroscopy repair. We repaired it and did an arthroscopic repair. And when we opened it, we did not use an anchor. And the difference was almost £1,000, which is about $1,500 per case. So I was wanting to ask Dr. Simone, what do you think about a anchorless cuff repair?
Anchorless? Do you mean regular transosseous without any anchors?
Just we use a drill in the bone, or what you call what the cobblers use. They just make hole and put the needles and you tie it. Because anchors are very expensive. I don't know why a small bit of plastic becomes $200, but they are very expensive.
No, really, a true transosseous suture has very good fixation. You can also use more points of insertion because you can put them very close. You can have very, very nice and neatly done. And also, if you look at it macroscopically, the times I've done transosseous, true transosseous, you look at it and you say, this looks great. And the fact that you a lot of times have to use double row and transosseous fixation is because you want it to look as good as it looks like that, because you want that stable fulcrum. So I think today we just use anchors because it is a bit faster. It is a bit faster than doing the transosseous fixation, but there is no other excuse than that.
Right.
Vivek?
I only have a little concern because, I mean, I'm sure that so many studies have been done regarding this and they don't find much difference. But my only concern with pure mini open where you don't put a scope inside, is, missing out the lesions of biceps, which remain the pain generator. You miss out the lesions of especially the subscap type 2, type 3. I'm sure that type 1, type 2 may not make a great difference, but type 3 and 4 certainly onwards, especially if you have the L-shaped tear or reverse L-shape, let's say in right side, when you have a subscap also. So if you repair the subscap well and you bring everything together, these patients do well. A massive cuff tear where you ended up just repairing the, let's say, the part of supra-infra, and you could not repair the subscap because you did the mini open alone. How would it not affect the results? That's why I'm always a bit concerned about pure mini opens. And the other point comes in the minute you put a scope in, you see, you have already got your saline, you've got the tubings, you've got the drapes, you've got everything. Once you have opened the system, then I don't know how the cost changes. Yes, maybe. And the expert arthroscopic surgeons who also once in a while do mini open, I myself have tried, it makes a difference of about 15 minutes. 10 to 15 minutes. So in 10 to 15 minutes, how much anesthesia charges and OR charges really make a huge difference. I don't know, but what Dr. Pandey said is important. If you don't use anchor, then it definitely goes down. So what's your concern, Pablo, regarding this?
So I think exactly the same. You lose your arthroscopic diagnosis if you don't put the arthroscopy in. So you have to do a very detailed previous physical examination, and you have to get very good imaging studies. You have to be sure there are no problems with, if you do only the pure mini open, you have to be sure the biceps is okay, subscapularis is okay, and the referred pain and physical exam on the patient is fine. If not, you have to put the scope in if you want to rule anything out, especially if it's a younger patient, for example. But and the other thing about putting the scope or not in, it does take a bit of surgical time, just the preparation of putting the scope instrument in the tower and everything, and the patient position. It is much faster to go straight with surgery, open surgery. Yeah,
I agree. And
one of the most important things. Sorry, Vivek, you go.
One more thing: the delaminated tears, especially the delaminated tears. Especially when you have the inferior layer going quite medial. And with this Sugaya studies and the lot of roll of capsules, so the inferior layer, it also has got a lot of attachment of the capsules. So I have always wondered that how exactly to see that layer, because that really goes medial. But if you do arthroscopy, you can really see and you can reattach it separately. So have you been able to see? I mean, I don't do much of mini open. I do once in a while, as you said, now somebody is asthmatic or anesthetist said, okay, you want to do finish fast. Okay, fair enough.
Yes. You cannot be as descriptive and as perfect as I think you should do with arthroscopy. That's why I have been shifting towards arthroscopy. And just one more thing related to if I should do one or the other, and what patient would make me do one or the other. Nowadays, I think bigger patients or more muscular patients, I have much less hard time doing arthroscopy than a mini open, for example. But and I'm also used to having a great vision with arthroscopy that you can see all those fine details that we now may take into consideration.
So I think one of the most important place for a mini open cuff repair is learning. When arthroscopic cuff repair doesn't come to you so quickly, you have to do many cases before you become efficient. And what I do with my fellows is that you say, okay, you start doing an arthroscopy. You don't want to spend too much time because the shoulder swells up. So you do some basic stuff arthroscopically, then you do a mini open. So next time you do the acromioplasty or prepare the footprint arthroscopically, then open and repair, do the operation quickly. So slowly and slowly, you move towards an all arthroscopic repair. Because just doing an arthroscopic repair can be difficult at times. And the first few you do, you take 2-3 hours and the nurse is getting in a faff, the anesthetist is shouting at you. There is a lot of water on the floor. So you can make life much easier for you if you go in a stepwise fashion. I don't know what others feel.
Yes, it's a great, the learning curve, I think, for arthroscopy is that way to go, from mini open to arthroscopic.
I would like to say one small thing. One thing we need to consider is if you need to convert, and an arthroscopy to a mini open, the surgery is not that nice as Juan Pablo showed, because once you've been working a while in the shoulder gets swollen, gets bigger, and there it changes a little bit. It's not the same result in terms of the incision and the aesthetical aspect of the surgery, I think. I don't know, what is your opinion about that?
I'm sorry to interrupt. I think Dr. Simone needs to go, so let us give a farewell to Dr. Simone. Thank you very much. It was a beautiful program and wonderful discussion with very beautiful case scenarios. Thank you, Dr. Simone.
Thank you. This was excellent. Thank you very much.
We will meet you soon.
Juan Pablo.
So we'll quickly move on to Dr. Gomez, because I think he's touched the hornet's nest of repairing a partial thickness cuff tear. So we had to sort of question what is his indication for repairing a, here we are, Dr. Gonzalez, Dr. Gonzalez says that he doesn't repair many full thickness cuff tears, and you show us how you did a partial thickness repair. So I just wondered, I very rarely, I mean, I don't think I've repaired a partial thickness tear. I've repaired one in somebody who was a 35-year representing England in swimming, very active sportsman. And then he never became a champion. After my repair, he just became a normal person. Before that, he was a champion in swimming, or England champion. But after my repair, he gave up swimming. But he's still happy that he has a painless shoulder. So if you're a 50-year-old, 51-year-old, and you see a partial thickness cuff tear, what would you do?
Okay, it's a very good question. In my lecture, I didn't speak about indications. I tried to speak about technical tips and just technical matters. So for partial tears, I have the same experience as you. It's not usual. Most of the times, the surgery is indicated when the patient has pain for a long time and is not doing well with physiotherapy. It's never a first indication for treatment, never. Most of the times when you do the surgery, it's because of another pathology associated, fundamentally a biceps instability, which has associated a pasta lesion. That you can see it more often. So if you have a young patient, 40-something, who has been treated with physiotherapy for a couple of months, 3, 4, 5 months, this can be pretty intense, the pain. So that could be my indication. It's not a lot. I would say I do maybe 5% of my patients, of my calf tear patients, are partial, and usually are pasta lesions with a biceps lesion associated.
Wouldn't just a subacromial decompression be enough?
Alone, never. No, but for a pasta lesion, you mean?
Yeah, for a partial thickness cuff tear.
But I mean, if the lesion is, if the tear is articular, I don't think
you can debride it and do a decompression. Can't you debride it and do a decompression?
Well, it depends on the size, as I show. If it is less than 50%, of course, I debride. I don't want to do the scenario worse. But if you sometimes you have, as I showed, patients, they only have 1 millimeter or 2 millimeters of tendon, that it's virtually complete tear. And those patients, for me, it's no difference to complete the tear and repair than doing a debridement in that scenario is not a good idea, because once you're inside, it's much better if you fix it, if you repair it, and the results of a partial tear are much, much better in terms of healing than a complete tear.
Dr. Gonzalez, do you have anything to say about partial tears?
I think very similar to Diego. I wouldn't operate partial tears in the first place. I would try to do physical therapy, but in persistence of symptoms, again, as the indication of a general indication, persistence of symptoms would be an indication for me to operate. I don't do acromioplasty for partial tears. I don't do acromioplasty for complete tears. I think the problem is in the tendon, not in the acromion.
I agree, especially if you have an articular site here. I mean, the acromioplasty, for me, has no sense to do an acromioplasty if you have an articular tear.
No, I'm not saying that that is the thing, but because most of the time the symptoms they would come with is impingement, like
Maybe.
symptoms. Even if they have a pasta lesion, you debride it, and you. My problem is if you have a pasta lesion, even if it's 50%, you are destroying the other 50% of normal tendon to justify repairing what you think of is much better than what the nature has created. So there is always two sides to every argument. Mm-hmm. And I'm just thinking, because I remember when in 1990s, when I went to America and saw some shoulder surgeons, they were repairing almost every slap lesion, every partial tears. And 20 years now, they have changed. Not many slap lesions are being repaired and not many partial tears are repaired. So okay. I was just wondering whether this enthusiasm for partial tear has sort of gone some logical way, or is just at the moment still not sure as to which ones you repair, which ones you don't.
No, I'm zero enthusiastic about repair and partial tears. I only do surgery if they are in pain for more than, it depends on the anxiety of the patient, but we take a limit at 6 months. Some patients, if they are heavily in pain after an injection of corticoids and doing 30 sessions of physiotherapy, that is indication, in my hands at least. Never as the first treatment, never.
Dr. Moya, do you repair partial tears sometimes?
Yes, in very specific cases in which conservative treatment has not given a good result, or we see that there is an increasing size of the partial tear. But, you know, as you were saying, things have changed and the approach have changed. How many of us, all guys, have underwent tonsil removals? And now it is not practice. So unfortunately, there are fashions in medicine, and we all go behind that fashion, and things change. But anyways, in fact, I think one good point that we have with rotator cuff is the follow-up before making the surgical decision. So if we are close to the patient, we give the patient all the information, and we have the chance to see the patient, examine the patient 2 or 3 times. In some cases, we will make the decision with many reasons for deciding for surgery. But if we pretend to make the decision just with one visit of the patient, in some cases that things are so clear that there is no it is not necessary to see the patient again. But in many patients, it is worth to see the patient 2 or 3 times. And that's why I like very much Sugaya when he said conservative treatment give you the chance to face the patient several times.
Vivek, you want to ask something?
Yeah, I will ask something and I'll give my bit. To Daniel, Diego, Carlos, do you ever consider among the, so all of us have agreed to one point that all partial cuff tears, all do deserve a trial of fairly long conservative treatment, at least ranging from 3 to 6 months, because I'm sure that all of us have burnt our fingers when we did do something to partial tear, and RK Pandey sir, in fact, that, ensured that nobody plays again. I mean, for that matter, all of us have gone through this, and we realize that we should not have operated because the condition can become worse. The pain can really become worse. Having said that, so in the trial of conservative treatment, how many of you do actually give steroid bar PRP? Because I yesterday examined a boy who is our own medical student. And he had in the September 2019 a it's like a footprint tear, a small footprint tear of 5 mm. And then he was continuing for his final MBBS exam, and after the exam he went home. His pain increased, and that's the time lockdown happened. So he got an injection given in PRP injection in Delhi, and then he came back. He did not respond, so I just saw him about 4 days back. I said, let's repeat an MRI. So now his tear size, same footprint tear, which is intact on the bursal side and articular side. It's just a small hollow, interstitial hollow, which has almost reached to 1 centimeter. So my question is, do you ever give a PRP bar steroid to these people, or when you do not give? I'm sorry, it's a long question, but yeah.
No, it's a nice, it's a good question. I do not use anymore for the last 15 years subacromial injections.
Okay.
There are no proofs, at least for me, that PRP are a good indication and will control pain. So what I use are steroids, one injection of a deposit steroid, but intramuscular in the gluteus. That's all. There is an old paper published in 1992 comparing the effect of giving the injection in the gluteus or subacromial, and the clinical result is the same.
Okay. Diego, Carlos, what's your opinion about this PRP? Because it's a bit, I also personally felt it's an hype. We have published our RCT post rotator cuff repair PRP in in JSCS, but not in this partial tear, because I have never understood why should we be giving PRP. So do you have any idea about this PRPs in the partial cuff tears?
I would say I have zero experience, but I think there is no evidence to support the use of PRP in calf tears in partial or complete. No strong evidence to use it. So I have never used it, and it's not in my plans to start.
Carlos?
I don't use PRP either. There is a strong commercial bias here in Colombia with the PRP, and no evidence behind that. More commercial bias, and we don't follow that trend. PRP, we don't use it.
Could I ask everybody, would you give one steroid injection at any point in a full thickness cuff tear? And what would be your indication? Or is it a complete no, never?
You mean in the subacromial area? Sorry.
So subacromial area, if your patient has got a full thickness cuff tear, a lot of pain, cannot do physiotherapy, would you consider giving one steroid injection or never? So let's start with Dr. Gonzalez, who's talking.
Yes, I think very alike to Daniel. I use steroids, subacromial steroids, in the extremes when the patient doesn't have a tear and have pain and some subacromial pain, and when the patient has a massive rotator cuff, when you are don't think that you are going to do a repair of that cuff. In the middle, when you have partial or small or medium tears that could be repairable by surgery in the future or in the near future, I don't use steroids in the subacromial space. I prefer in those cases to use intramuscular.
Do you think if somebody's had a steroid, your surgery becomes difficult?
Not difficult in terms of technical difficulty, but in terms of prognosis. The steroids, and there are some papers that support that, the steroids could alter somehow the prognosis of the patient. And if you don't operate the patient fairly close to the steroid injection also could give some atrophy to the tissue. And then when you do the surgery 1 year later, the tissue is not going to be the same. So I think there are two things. One, when you do the surgery in the next 3 months after the injection, you could have even a little more infection rate. And when you do a little, but you can have that. And when you do the operation 6 months or 1 year after the injection, you are going to have less good tissue. So I don't like the steroids in the subacromial space when you are thinking in the possibility of doing surgery in the future.
Right.
I think it was nicely expressed by Juan Carlos, the idea of the extremes. I agree with that, and I agree with the evidence about 3 months. There are some papers showing worse results in terms of healing if you do a corticoid injections 3 months before surgery. Has been proven. So if I have a patient who is probable to have surgery in the next couple of months, I don't do an injection at all.
No, but if you have already decided that the patient is going to have surgery, then of course you don't want to give a steroid injection. But if the patient comes to you first and he's got a small or a medium tear and you want him to have physiotherapy, and it may be a good chance that that may avoid him having surgery, will you consider a steroid injection?
Yes, let me tell you my experience. I have done my fellowship in France, and the Social Security in France obligates the surgeon to do at least 1 corticoid injection before surgery. So many times when they see the patient with a surgical indication, they send the patient to do, they don't do it, the imagenologist do the injection, and they have to do it. So all the country do the same, and all calf repairs have a previous injection in the shoulder. Being said that, what I do, most of the times it depends if it is mechanical or if it is inflammatory, the symptom. If you have a patient with a mechanical symptom, and if an injection of corticoids has little sense. But if you have a patient which the main problem is inflammatory and he has a balanced shoulder with a small tear, nothing scaring, I think it's a good candidate. And if I do an injection, I still will give him 3 or 6 months. So it's time enough to clean out, to wash out the injection if I need a surgery later.
Okay, so can we move on to the next question I wanted to ask everybody, and then Vivek can finish it off for us. When do you move your patient's shoulder after your cuff repair, be it open, be it arthroscopic? In 1990s, when I started doing, we used to put them in an aeroplane splint, similar to what Dr. Moya showed the spiker. All our patients were in an aeroplane splint, and they used to knock a lot of people around at home and in the market. And then slowly it became a normal sling. And now some of my colleagues don't immobilize at all. They want the patient to start moving the next day if he can. So what is everybody's philosophy here? Let's start with Dr. Moya and then we'll move.
Okay, I agree with you. We went from that airplane to moving the patient the next 48 hours after surgery. In the
any size tear.
Yes, yes. And we all realized that was not a good idea. And we didn't confess that at the congresses, but we moved to be more conservative. And now I am using the sling for 6 weeks. In some cases, if there are very small ruptures, I just use it for 4 weeks. Of course, the patient begins with elbow exercises the next day after surgery, but I ask the patients to use the sling. I do not have problems with loss of movement, so I want to preserve the repair, especially if there are big tears. I prefer the patient to be with an immobilization of the shoulder for 6 weeks.
Dr. Gomez?
I think generally slower is better. I would say for small tears, 1 month, for bigger tears, 6 weeks, as Daniel said. But I think it's, you need to consider the IQ of the patient. If you have an intelligent patient, it's not the same that if you have a hard worker, a little bit dumb patient. I think those patients, you need to stop them. It's not the same. And also you need to consider your time. If you are in a heavy practice, it's really difficult to, and it depends on the system you have around. It's very different to guide a patient with a fast move recovery if you are doing, I don't know, 5, 6, or 10 calf a month.
Mm-hmm. Dr. Gonzalez?
I go a little faster. I like to do mini open rotator cuff tears with no acromioplasty. And I am very confident with the quality of the stitches and the strength of the suture. So I begin very fast. I recommend the sling for 4 weeks, but 1 week after surgery, I begin with passive motion with the patient supine in a controlled way by a physical therapist. And I recommend the patient to use his operated arm in a daily living fashion after a few days after surgery. I mean, to help him to dress up, to help him to have his food, and to help him to do his personal hygiene with his operated hand very fast.
Right. Vivek, what do you do?
Yeah, I think somewhere, a mix of all three. I think I also take a very, very important point from Diego that not all patients are same. Some of them are dumb, and in medicine, it is said that if you ask them to go for an inch, they'll go for a mile. So you have to be very cautious. You explain them that what they can do, as what Dr. Carlos was telling, that you can allow after a few days if the repair is reasonably good. Not all repairs are same. So if you feel that repair is reasonably good, then, after a few days, I ask them to remove the sling, like sitting and watching the TV. Okay, you can remove it, having coffee, tea, brushing teeth, some hygiene. But then walking night and outside. See, once they go outside the home, the other person doesn't know that he has been operated. They may just shake hand or they just pull the hand. So at home, yes, sometimes they can remove, but not outside. And as I think Burkhardt also says that it's better to have a little stiffness, which will eventually improve. And that has to be part of counseling. It's like rotator cuff. I always tell them it's one pregnancy time. By the time they regain the near normal movement and strength, it's about 6 to 9 months. And if they argue, I said them, the God doesn't allow him to come at 2 months. How do you expect me to give you at 2 months? So it's better to go slow rather than accepting a re-tear, which is considered as if so-called failure. Whether it did not heal because of biology or my surgery, I don't know. But smaller tears, medium-sized tear, some partial tear, which the Diego shows where you can do a double row quick. So, and you have to go faster because they become very stiff very fast. So every tear, I think we should deal a bit differently. But larger tears, you got to be a bit cautious. Subscap, you allow them too much of external rotation, they just re-tear, because 99% of people do a single row subscap repair. And it is one tendon which tears frequently, and it's hardly ever assessed because nobody actually assesses the subscap. Everyone assesses only the supra and infra. So overall, I take the middle path of all three, Daniel, Diego, and Carlos, somewhere in between. Not too fast.
I think the important message here is it has to be patient specific, the rehab, rather than having one thing which fits all. You have to be patient specific.
Absolutely
correct.
One point I have to bring about the partial tears, Radhakant sir, which is I don't know about the the Southern America's approach, but I have been very, very closely following these partial tears in the middle age, this 40 to 55, and the question comes is why they should be operated a little bit late. Is you have to be 100% sure that this is the cause of pain generation. Unless and until I'm sure, I would not touch him. Be it 3 months, be it 6 months, be it 9 months. And in these patients, men and women, I always do their sugars, glycosylated hemoglobin, and if they are women, the thyroid profile, invariably. And if any one of them is positive, then the management goes on that line. Because a small partial tear, bursal or articular, in a pre-diabetic, and you go and touch him, trust me, you will repent all your life. And that's how the first time in my life, about 8-9 years back, I learned whom not to touch. Those are the patients where you have to be very, very categorical. If somebody is pre-diabetic, borderline diabetic, just diagnosed diabetic, and he has got one MRI, small partial cuff tear, do not touch. It is like, do not touch. You touch, you will repent all your life. And there comes the role of injection. So Pandey sir, you were asking, so in full thickness tear, as most of them agreed, they would not inject. And I love the idea of Daniel Moyer. Next time I'll give them in buttocks. I have always been giving in the shoulder, but in partial tears, I'm relatively liberal, especially on the bursal side. Articular side, as Diego was trying to say, they are mostly mechanical. So I don't know how much they help in articular side, but bursal side, I usually give them. So yeah, that's my take roughly about partial tear. I'm very, very worried about this glycosylated hemoglobin altered.
Vivek, I have a presentation against the subacromial injection with a lot of information about why not.
Okay. So next time, Daniel, we would love to listen to you.
Why that?
Why not? Yes. So that
okay.
was my take about.
I think that was a very, very beautiful session with lots and lots of lovely and interesting case scenarios. And there was lots of things to learn from each other because the protocol is quite different in different places, and the spectrum of patients is also very different. In the UK, it is more likely to be like the older group of patients, and in India is possibly the younger group of patients. And Dr. Moya, what are the spectrum of patients you get over there? Like you get more older geriatric patients, or?
No, I would say that perhaps in the middle,
Yeah. Okay. So we had a mix of all discussions here. I think it was a very, very beautiful session, and this recorded video is going to stay, and anyone will be able to watch it in the future also. I'm totally grateful to every one of you for making this a wonderful session, and we learned a lot out of it. You have anything else to say, anyone?
Just to thank you. We feel very comfortable. It was a pleasure to be in touch with such a high quality colleagues, and I enjoy very much this discussion.
Thank you very
much.
Yeah, thank you very much. We possibly will meet up soon
Adios,
in the
amigos.
future.
Thank you. Adios. Thank you very much for the invitation. Thank you. Nice to meet you all.
See you all again together.
Goodbye. Goodbye. Thank you very much.
And thanks, Rini.
Thank you, Dr. Pandey and Dr. Pandey, and Dr. Carlo, Dr. Diego, and Dr. Moya, and Dr. Srinivas. Thank you all.
Thank you very much.
Bye.
Goodbye.
Good night.